now. We are recording, and I will start the slides, and hopefully you're all seeing my slides. So this is the class you would have gotten 3 weeks ago, I guess it is now. The structure of the healthcare system. And system is in quotes because it's not really much of a system. And hopefully you got that from the readings. Since everybody's on mute, we probably won't go through these questions, but I hope you did get some from the readings, the understanding that the system is very fragmented. It's patchworked. It's not integrated at all. There are not gaps that people fall through. It's chasms that people fall through, and you would never build it this way if you started from scratch. On the public health and equity readings, and we'll get into this a little bit, is I wondered what you made of the HHS spending chart. This is the Health and Human Services at the federal level, billions of dollars that's spent on healthcare, and a tiny, tiny fraction is spent on public health. And we'll talk a little about why that is and how to be an effective public health practitioner in that environment. And then also we'll talk a little bit about equity, but since we've got a lot going on in this class right now, we won't dwell too long on that, but that it'll be a thread that runs through many of the things that we talk about. So I just love this quote. It's no use carrying an umbrella if your shoes are leaking. I use it all the time. But a really important point that the healthcare system is not, as sometimes you jury rig something to find out that you've got a bigger problem. And that's just a common theme across the healthcare system. You also, I was not able to make this work today. I tried very hard, but there's a great video, I think it's about 3 minutes from this link about a healthcare system that actually works, with a little surprise at the end. You should really go to it. It's quite funny. So healthcare is an incredibly important sector of Connecticut's economy. 12 cents out of every dollar spent in Connecticut goes to healthcare, over 30 billion, and that was in 2009. I'm sure it's much more now. And 1 out of 8 Connecticut workers is employed in healthcare services. That's healthcare services. That's not public health. While Connecticut employment dropped 4.3% in the last recession from 2008 to 2009, healthcare employment was up 1.7%. People need healthcare when you need it, and it's something that people will prioritize to pay for. There are 10 major drug companies and 22 biomedical companies, as well as 6 major insurers have very large facilities in Connecticut. Every dollar spent on Medicaid in Connecticut creates $2.09 in business activity, and Medicaid generates over 30,000 jobs and $4.5 billion in Connecticut wages. Drug companies, Pfizer alone had over $52 billion in sales and over $11 billion in profits in 2004. You can't outsource healthcare jobs. When you need a nurse at the bedside, it can't be done from India. And the jobs range from very low to very highly skilled, requiring varying levels of education. We'll talk a little about that, about the providers who provide care in this system, unquotes. But it's a very big part of Connecticut's economy. And whenever you have a lot of money around something, there's a lot of attention and energy, and the status quo is very strong. So as wacky as this system seems, you're going to understand that it's going to be very, very difficult to change. Healthcare is expensive in Connecticut. It's expensive everywhere, but it's much more expensive here. Our healthcare spending per person is 27% higher than the U.S. And from 2000 to 2011, Connecticut total family premiums rose by 85%, and household incomes rose only 23%. People are moving backwards in terms of their ability to afford healthcare. We're also not getting what we pay for. We pay a lot of money, but only about 51% of Connecticut adults over age 50 receive the recommended screening and preventive care that they're actually paying for. 17% of Connecticut residents with asthma visit the ER annually. That's unacceptable. And 11% of Connecticut hospitalizations, costing $1.2 billion each year, could have been prevented with better access to adequate primary care. We could save $1.2 billion if we got people primary care and kept them out of the hospital. From July 2004 through September 2009, there were 1,224 serious medical errors. These are serious harm that happened to people in Connecticut hospitals, and 116 of those patients died. The quality of care is not acceptable. 7,000 Americans die each year because of adverse drug events. They got drugs that didn't interact with each other. And preventable hospitalizations account for 11% of all Connecticut hospitalizations and charges. So our system is dysfunctional in terms of its output. Now let's look at how it's organized, and organized should be in quotes as well. There are three different levels of healthcare. Primary care, which is the least expensive. It's the first stop for patients. It's 80 to 90% of healthcare visits. Those are for common health problems. When you go to the doctor for a prescription or you've got an ear infection, that's primary care. It should be a permanent connection between the patient and the provider. You should have someone you go to on a regular basis. Secondary care is somewhat more expensive. It requires more specialized clinical expertise. For instance, a hospital stay for renal failure. That's secondary care. Tertiary care is the most expensive care, and it's only provided in certain centers around the country. Connecticut has two. Management of rare and very complex disorders like pituitary tumors and congenital malformations. There is no formal structure, unlike in other countries, of movement through the levels in the US. Patients can self-refer to specialists. There are quite a few people actually with complex conditions who only see specialists. They never see a primary care provider. They don't start with prevention and sort of triage across the body. They start right with a specialist. That leads to fragmentation and very costly overtreatment. How do patients move through the system? It kind of depends where you start. In other countries, there's a progression that you're expected to go through, and we'll learn more about that when we talk about international healthcare. But it does here depend on where you start. If you're uninsured, you may start in a clinic. You may start in the emergency room. If you have really good coverage, you may jump right over to going to a specialist. It really depends on where you start. There are very great variations in access and quality. It's got to do with what healthcare program you're on, if you're on one at all, income, educational level, your payer, geography. If you're far away from a hospital, it really doesn't matter if you're a millionaire. You're not going to have as good access. And race and ethnicity, and we'll talk about that. Family support is critical. Having people who will support you makes it much more likely that you will be able to move through the system. You'll have an advocate to work for you. And self-advocacy skills, which are really important in being able to, somebody has a question. Let's see. Maggie asked, are they not receiving it because they can't access it or because they're not seeking it? Great question. People, both, all of the above. And it's hard to tease out exactly what the issues are. For some people, mental health issues are keeping people from being able to access primary care. For some people, we do have a primary care shortage, and I'll talk about that. So they're trying to access it, but they can't. Other people, just avoid going to the doctor. Men especially have real problems getting the care that they need. So it's a little of both. Patient characteristics, difficult patients, 15%, as high as 15% are seen as difficult patients. These are people who don't show up for appointments, don't take their medications, don't do what the doctor tells them to, or do exactly what the doctor told them not to do. It's often undiagnosed mental health issues. And the other thing that matters a great deal about how you move through the system is just dumb. There I am. I muted myself. Thank you for letting me know. Okay, Kira had a question. Where is Kira? There she is. Oh, no, the question's gone. Okay, I'm back. Coverage in Connecticut. Being able to access care in Connecticut is really important, dependent on whether you have coverage. If you look at this graphic, that's the yellow are people. This is an infographic, a representation of Connecticut's 2011 census. Didn't change a whole lot. It will have changed for last year, but we don't have those numbers yet with the Affordable Care Act. We'll talk about that later in the semester. But the yellow is private employer based. You can see the vast majority of people in Connecticut have coverage through their employer. A large number in red here directly purchase coverage. And if anybody's tried to do that, that's not cheap, especially before this year. This right here is Medicaid. That will change significantly. 489,000 in 2011. It's almost double that now because of the Affordable Care Act. Medicare is about 500,000 people in the state, and the uninsured was about 300,000. We're not sure what it's going to be as we move through the Affordable Care Act and implementation. There's also been a significant shift, and the Affordable Care Act is going to speed this up as well, of people moving out of employer-sponsored coverage and into public coverage. Public coverage is Medicare, Medicaid, by and large. And that has significant implications as more and more people move on to programs that are funded through tax dollars as opposed to employer premiums. It will see more access problems, and we'll also see more problems with covering things because private payers generally pay providers more for each treatment than public programs do. But we'll talk about that a little as well. Okay, whoops, sorry about that. Okay, let's talk a little about the providers in the program, in the healthcare system. There are great variations in income, prestige, and autonomy. That's not surprising. One thing I read or I saw an NPR story, did you know that nurses' aides are one of the highest, most likely to be hurt on the job of any any workers, more than construction workers, more than police officers, more than corrections officers. It is a very, very hard job. And then you go up to CEOs of very large insurance companies, doctors. There's a great range in income and prestige and autonomy, the ability to direct your own work. There's great variation in educational requirements. Obviously, being a doctor requires medical school, a nurse's aide requires less. Debt loads are driving practice decisions for doctors. Doctors, it was a few years ago, were leaving school with $200,000 in debt average. That's a lot of money. And so to pay that back at a time when you're coming out and you want to start a family and start living your life, it makes it more attractive to become a specialist as opposed to a primary care provider. You can't work your way up in healthcare. You can't start as a nurse like you can in, say, a factory. You can work on the floor and work your way up into management. You have to go back to school if you're a nurse's aide, if you want to become a doctor. And there are really deep concerns in Connecticut and elsewhere about the supports for people to move up that ladder. Education's expensive. And for a lot of people, once you've started, having a family, it's a lot harder to do. There are life supports that are needed to be able to move up the ladder. There are quality of life and workplace issues. As I said, it can be a dangerous job. People don't think of it that way. Nights and weekends. People need health care nights and weekends, and that's not the case if you're working at a desk job. There's a real trend toward team-based care, which is a good thing. And we'll talk about that at the end of the class when we talk about delivery reform, where we are changing the way that care is provided. You won't just have, one patient will have a doctor. You'll have a whole team of people. It'll include a nutritionist, possibly a behavioral health specialist. It may include a nurse and a nurse's aide. It may include other kinds of specialists as you need them. There's an entire team of people who jointly take responsibility for your care. There's a trend toward data, big data, and evidence-based medicine. There's been this sense that medicine was more of an art than a science, and there's a strong trend that it should go back to being a science. There shouldn't be so much variation. There is, best evidence about good ways to treat different kinds of diseases, and we should be following them. There's a higher level of accountability for providers than there has been in the past. They have to justify the value of the care at their level to show that the same quality of care could not have been provided with fewer visits or by another professional, and maybe that might have been more effective. And mid-level providers and community health workers are a new part and a growing part of the provider community. It's not just nurses and doctors. There's a lot of other people across that continuum that I was talking about, the variations in income and prestige, and having a real role, an important role in the healthcare system. So Connecticut providers of care, there are 36,320 nurses, one of or maybe the biggest workforce category in Connecticut. There are 13,703 actively practicing doctors. There are about 18,000 who have licenses, but many of them are not actively practicing. They may be working in administration, in a drug company, they may be retired. There are about 1,700 physician assistants, 3,400-ish nurse practitioners. Nurse practitioners that last year's session won the ability to practice independently. This was very controversial. The medical societies all opposed it, but now they do not have to have a supervisory relationship with a physician. Physician assistants still do. And there were questions about quality, but when the legislature really looked at this, they found no evidence for a lower level of quality of care as long as nurse practitioners were working within their scope. If they're not trained to do it, they shouldn't be doing neurosurgery. But within their scope, there's no evidence at all that there's any lower quality. We have 28 acute care hospitals, 237 certified nursing facilities. We have 13 FQHCs. These are federally qualified health centers. These are community health centers, and they are federally qualified, means that they get federal money, and they're situated in places which are underserved, where there aren't enough primary care providers to provide care to people who have difficulty accessing care, which generally means the uninsured and Medicaid. Those 13 clinics have 152 sites around the state, and we have 7 licensed free clinic sites. One is a mobile van, Malta House of Care, in Hartford. 4 are run by AmeriCares in Fairfield County. The others are generally community organizations or church-based organizations, and these are completely free clinics. They're for people who are uninsured. They're run generally with volunteer healthcare providers, but they're licensed by the state. And we have another question. Let's see. Somebody else can't hear me. I don't believe that I'm on mute. I shouldn't be. Can you all hear me? I'm assuming you can hear me. I hope so. Yeah. Okay. Provider dynamics. Connecticut provider dynamics. There's serious ongoing scope of practice tensions between different sets of providers. Optometrists, ophthalmologists, and opticians are sort of, when I started in the public health committee, that was very, there were a lot of strong and tough bills in describing who could do which sets of treatments within the array of providers who provide health, visual care and vision care. Dentists, hygienists, and now a new advanced dental hygiene practice practitioner designation has been suggested. Doctors, nurses, nurse practitioners, and physician assistants. These are big areas of healthcare, very highly lobbied and very tense ongoing scope of practice tensions. There are groups there's sort of a progression for groups who move through working on getting recognition. Generally, they argue for inclusiveness very early on and recognition. Then they go to where they just basically are registered, say with the Department of Public Health. Then go to certification, which requires some usually self-attested certification of qualifications. Then licensure is the next one up, and then being able to bill to insurance companies is important, and then eventually independent practice. And it's sort of a ladder for professions. They usually argue very early on for inclusiveness, and then they switch to exclusion as they move up the ladder to protect what they've accomplished. Why are there so many nurses compared to doctors? Jackie wants to know. That's a great question. To some extent, we need more nurses. Nurses when you think about the time when you're in a hospital, for instance, you're seeing nurses for hours of every day. You see the doctor maybe once or twice in a day. So we need more nurses than doctors. And nurses work in far more different and varied settings than doctors do. So we just need more nurses. And I think that's it for questions. Oh, wait, let's see. It is true. Monica noted that it's not only cheaper schooling for lower levels on there, but also it's less competitive for admission. And that's very true. Although I'm not so sure anymore about nursing, to be honest, given actually it's been interesting to look at to see whether it's harder to get into nursing school than medical school right now. I don't know about that. Oh, rats. Didn't mean to go that far fast. Payment levels vary widely for the same service across the healthcare system by timing, by payer, by geography. Sometimes just getting something in Fairfield County can be a lot cheaper or more expensive, than it is in New Haven County. Visibility in the market. There's a lot of advertising that happens, and so people tend to go to those places that they see as visible in the market, and they can charge a higher price for that. If you're going to a safety net provider, say a free clinic or a community health center versus a commercial facility, a more private pay, some of them can be exceptionally expensive. Some of the private pay hospitals, especially the ones that refuse to take any insurance coverage, they can be very expensive. State facilities versus private, obviously, people don't pay generally for care in state facilities. They do in private. And there are advantages set in law and regulation. For instance, community health centers get paid a higher rate from Medicaid than private pay doctors do, surprisingly. Most people would think that clinics would be paid less, but they actually get paid more, and that's federal law. And it's because there's an understanding that they're also they're also seeing people who don't have any insurance, and it's meant to cover that. So some of those advantages, for instance, we required in Medicaid plans, when we had Medicaid insurance plans, that they include places like Planned Parenthood, school-based health centers in their Medicaid plans. If they're required to have them, then there's not a lot of competition and they can charge more. Hospitals and doctors have traditionally been at, I don't know how to put this. There's been some tension between them, and that plays out. That's just historic and traditional, and it's not specific to Connecticut. That plays out a great deal in provider dynamics and large, small practices, large versus small ones. Connecticut has typically had I think it's 80% of doctors in Connecticut, physicians, practice in practices with 5 or fewer physicians. So we're a small practice state. And that sort of independence has been a real thread through Connecticut, the Connecticut Yankee um, uh, ethic. And so there's a tension between small and large practices, and then with hospital-based practices, there's a real shift. Hospitals now are buying more and more primary care practices, and that's a big dynamic that we can talk about when we talk about the market. So let's look at how many MDs Connecticut has per population. This is the US average, about a little less than 3 per 1,000 people. Connecticut has almost 4. We have a lot of doctors. The US average for this is specialists. In US, a little bit higher. In Connecticut, the disparity, we're a little bit lower for primary care and higher. So that higher number is mostly specialists in Connecticut. And that really drives up costs. We'll talk a little about that. But does Connecticut have too many providers? This is the ratio of Connecticut to US per population. So 1 would be if we were at the national average. We have fewer hospital beds than the rest of the country, but we have more nurse practitioners, more physician assistants, more nurses, and more doctors. Connecticut does not have a de facto problem with access to care. It's not that we don't have enough workforce. I talked about this a minute ago, but how do providers drive up costs? It's been said, whoops, what did I do? Nope. Yes. Do providers drive up costs? It's been said that the most expensive piece of equipment in healthcare is the doctor's pen, and that could be true. It's called supply-sensitive care. Doctors can, if a doctor tells you you need something, you generally get it. It's not, your car salesman can't say, I really think you need an SUV or you need a minivan, and you'll do it. But in a way that you don't have full information about what you need, the same way you do when you're buying a car or you're buying something else, that the healthcare market is seen as one that is supply sensitive. So as you have more doctors, they can say you need more care, and generally you get it, and it drives care. Discretionary treatments are more common in areas with more providers. They just are. It is not a typical market. As I said, providers can drive demand for their services. It is rare that patients argue with the doctor's recommendation. They're trying, many groups are trying to get people to ask more questions of their doctor. Why do I need that x-ray? Why do I need that EKG? But it's rare that people do that. And there's a lot of research that shows with areas with more providers per population have higher total costs of care per person, which Connecticut bears out. We have more providers per capita, and we have higher costs of care per person. And there is no evidence of better quality or outcomes for all that spending. No better patient satisfaction levels. There's less care coordination. And actually, the next slide is from a New England Journal of Medicine article. But you can see these are the regions with the lowest quintile of support, the lowest 25% supply of physicians. This group of areas in the United States has 169 per 100,000 population physicians. Regions of highest supply have 278, they average. So it's 60% more. More primary care, more medical specialists, more surgical specialists, more hospital-based specialists. But you look now at quality scores for heart attacks, not a big difference. You can see by the ratio of highest to lowest, you see very large differences between these sets of regions of the country in terms of the numbers of providers per capita, but you see far less difference. As a matter of fact, no difference in pneumonia. It's a little bit lower, to be honest, in the highest groups. And patient satisfaction, actually, access and satisfaction. Have you ever had a problem and didn't see a doctor? Do you have a particular place for medical care? Are you satisfied with your ease of getting to the doctor? That should be a whole lot easier to do here, but not really. It's actually a little bit lower than it is in areas with fewer doctors. Are you satisfied with the doctor's concern for your overall health? And are you satisfied with the quality of medical care? And you can see the quality of care just doesn't differ all that much when you have more providers. So let's talk about primary care, which is what we don't have enough of. Areas with more primary care providers had lower total per person costs and better outcomes. Specialists cost more, and they tend to find more problems. If you have areas with more primary care and fewer specialists, you get lower hospital admissions and more preventive care. And there are several reasons for this. Let's see. You get better access to needed services. Coordination and continuity of care is much better because it goes through your primary care provider. There's a greater focus on prevention, not surprisingly. There's a focus on the whole person, family, and community. Your primary care provider is much more likely than your specialist to ask about your family or where you're living or the community you live in, ask about a child's school. There's early management of health problems, doesn't tend to wait as long if you go to primary care, and less costly. There's less, so if something costs less, there's less incentive to overtreat or to refer somebody. And there's just a closer connection, a continuous connection to patients, and better health outcomes in areas with higher primary care. All-cause mortality, heart disease mortality, stroke mortality, infant mortality, low birth weight, there's better life expectancy, and better self-rated health. It's just better when you can see primary care rather than specialists. Unfortunately, we have a shortage of primary care providers in Connecticut. If you remember that slide that I showed that we have fewer per capita than most other states. One of the reasons is they're paid less than specialists. And as I said, doctors get out of school with a lot of debt. Fewer new doctors are going into primary care because of the debt levels, because of the income, also the prestige and lifestyle issues. I remember when I was thinking about medical school, a doctor told me that I should think about dermatology because he said there's never any there are no nighttime emergencies in dermatology. Let's see. And Kira asked, is the higher number of specialists need-based? Are chronic diseases higher here? Actually, no. We do have slightly, actually, no, Connecticut is healthier, to be honest. So no, it's not. It's probably, to be honest, because Connecticut's a wonderful place to live. We also have 2, now 3 medical schools, and people tend to stay where they went to school. It really isn't need-based. If you were planning this system, you would never build it this way. And doctors get to choose where they practice, not necessarily based on where there's need. And even within Connecticut, there are areas of underservice where that's where the community health center is set up. So even within Connecticut, where we have so many specialists and so many doctors, there are still areas where it is really hard to get access to care. And the community health centers, like in New Haven, the Fairhaven Health Center and the Hill Health Center are the 2 that serve the New Haven community, are set up in areas where, despite the fact that you're in the shadow of Yale New Haven Hospital, it can still be very difficult if you're low income, uninsured, or on Medicaid to get access to care. So, I mean, in other countries, there is planning around this. They look at the population. They say we're going to need, people are getting older. We're going to need X number of geriatricians or X number of internists, and they open new slots at school. We don't do that in the United States. It's very random, frankly. With primary care, there is more accountability and paperwork and more reporting because you are dealing with the entire human being and all the systems. New technology demands with electronic health records, patient empowerment, which is a good thing, no question about it, but it's also making it harder for doctors because they have to explain why you read something on the internet. They're having more discussions with people about their health care. Michelle asked a question. In order to properly utilize a primary care physician, a person should go regularly, not just when they have a problem. Absolutely true. Absolutely true. But even when you do have a problem, you should have a provider that you have a relationship with, so they already know your history. They know, what you're allergic to, what surgeries you've had. They know your history, so that when you call them, they can do a better job of helping you through that. They may also know what medications you may have tried for this problem in the past that worked or didn't work. So yes, you should have a relationship with that person, and you keep that by keeping up with your the schedule of checkups that you need to have. The Affordable Care Act is adding to the demand with new enrollment. More and more people are getting health care and they're paying for it. And so they're going to see their doctors. And the first doctor they see is their primary care doctor. And they are also not allowed under the Affordable Care Act to charge copays. That's the amount that you pay, when you go in for every service. You pay $10, $25, $35. They're no longer allowed to do that on prevention. Well, since primary care spends so much of its time on prevention, there are no copays on prevention. And unfortunately, we don't pay for prevention as much as we don't pay as much for a doctor's visit to give you a vaccine as we would for him to treat the disease if you were not vaccinated. We also have an aging population, which is making it harder on primary care providers, just increasing the prevalence of chronic illnesses that need management. Okay. In Connecticut, this was a recent survey done, I think, by the Medical Society. 28% of internists and 26% of family practitioners in Connecticut are not taking new patients. And that was before January of last year, when we added 130,000 more people to the Medicaid rolls and another 70,000 to the health insurance exchange. And between 22 and 25% are considering a career change. They're talking about getting out of primary care. The solutions are pretty simple, really, but unfortunately they take money. We need more training slots for primary care providers, residencies. Primary care rate increases. We should be paying just as much to prevent a disease as we do to treat it. Obviously, those incentives are just not sensible. Team-based care is making a big difference in allowing people to share the responsibility of making sure that a person, say with diabetes, is getting all the care they need if they share it with a social worker and a nutritionist and a team of nurses and other people in the community that they can refer to help people live a healthier life. That's going to make a big difference. Larger groups and hospital-based practices have grown in part because they are relieving the administrative burden. If you have a group of 5 doctors, you have a group of 50, some of those administrative credentialing and things are the same between them. So you can get some economies of scale when you move into larger groups. So that is one of the solutions. And specialists providing more primary care. I mean, you can't grow doctors overnight. And we have a very large need. So we may there's discussions about allowing specialists, and in fact, it's really happening just because people don't have any choice. Specialists are providing more primary care. And then also those mid-level providers that we talked about, nurse practitioners and PAs are also helping with the primary care shortage. They're an important part of the solution. Let's see. Jacqueline asks, why are family practitioners not taking new patients? Because they're full. Because we have a shortage, and it's a serious, serious problem. Let's see. Somebody has a question. Jacqueline, are you there? Do you have a question? Oh, I guess she's on mute. And Kira has her hand up. Did you have a question, Kira? Nope, I guess not. Okay. Then we will move on. Let's see, the nursing shortage. So it's not just doctors, it's also nurses. Nurses are working on longer shifts with reduced staffing levels. It is stressful. Like I said, nurses' aides and nurses as well have very high rates of on-the-job injuries. Longer shifts and reduced staffing levels reduce quality. You are more likely to die in a hospital if nurses are seeing more patients. It makes sense. There are a lot of reasons. It's a very hard job, and it's getting harder. Patients are getting more complex in the hospital and difficult. A lot of people who had sort of more easier, less complicated problems are being taken care of at home or in a doctor's office. So the people who do end up in the hospital are very complicated cases. Nurses are aging, the same as the rest of the population. And as Connecticut is not unlike other states where the number of people with complex care needs is growing. It's not, we're still healthier than the rest of the country, but the whole country is getting the level of complex and chronic illness is rising across the country. There are not enough slots in nursing schools for qualified students. We have a faculty shortage in nursing schools. They can often make more money in private practice. And so that creates a chicken and egg problem, because it's hard to get people to provide training if they're working in a workplace where they just don't have as much time as they used to help give back and train new nurses. So nurses are leaving the bedside, unfortunately. It has eased recently with the recession. Nurses who were going to be retiring weren't able to because their 401ks tanked like everyone else's, but it's expected to return because the population is aging, and people are we're coming out of the recession. Hospitals, another big part of Connecticut's healthcare system. We've seen more mergers, many more mergers across hospitals. For-profit conversions have been talked about, and new companies have tried to come in from outside to buy hospitals, nonprofit hospitals. Tenet recently came in to buy, I think it was 3 or 4, and the state actually put in place some important regulatory barriers, which they felt were too many. It was too much, and so now they're not coming to Connecticut. But they haven't been successful to date. But I'm sure that won't be the last time we'll hear about that. There are for-profit quality concerns, but there are benefits as well for hospitals that are struggling to make ends meet. Mortality is higher in for-profit hospitals. Staff tend to be cut. There is less uncompensated care provided to people who can't pay their bills, the uninsured and underinsured. There's less investment of profits. Sometimes those profits that used to stay here in a nonprofit, they stay here in Connecticut and go to buy, more beds or upgrade equipment. Now they will be leaving the state to go to Wall Street or wherever. And there is less community involvement. You don't have a community board of directors making decisions. You have somebody off in Dallas or somewhere. And there's less transparency in for-profits. Nonprofits have a lot of, trust me, as someone who runs a nonprofit, we have a lot of requirements about what we have to report to the government. But some of the benefits are access to capital. They do have the ability to raise money in ways that nonprofit hospitals don't, and that can be critically important to stay on top of, keeping a facility that's that high tech running. There are financial pressures similar to other providers. They are reduced admissions. Fewer people are going into the hospital, which is a good thing. And when they go, they're staying less time. They are getting, because of the Affordable Care Act, they are getting penalized and rewarded for quality of care they provide. And Connecticut's hospitals have taken a lot of hits lately in quality for people coming back into the hospital within 30 days with the same problem. They are responsible for patient satisfaction. They need to keep us happy when we're there. And for readmissions, as I said, and for population health. They're responsible for the people who they care for, not just to stitch them up and throw them back out, to actually make sure that people stay well. And there are lower subsidies for the uninsured. They used to get millions of dollars over $100 million every year in Connecticut, hundreds actually, of money for the uninsured. But the Affordable Care Act has cut that because fewer people will be without insurance. But that is a cut to the bottom line of hospitals. And then there's the safety net. The safety net is defined as providers who accept patients regardless of their ability to pay. That's not necessarily the same thing as free care. Free clinics don't charge anybody ever, but community health centers do. They charge based on your income, and hospitals definitely do. If you go into the emergency room, they will take care of you, but they will send you a bill. It may be a very big one, and they will collect on it as well. But those are safety net providers are those who accept patients regardless of their ability to pay. They don't turn you away if you can't pay for it. So it's hospitals, community health centers, free clinics, school-based health centers are included as well. They tend to be staffed with more mid-level providers. Many are grant funded, but they're shifting to being able to bill to different types of insurance. They're having technology challenges sometimes because they don't have as much, these big endowments as other parts of the healthcare system in coordinating with the rest of the system. But the state is stepping up and trying to do something about that. Some are not as well funded. Some are better funded. As I said, community health centers get more for a well child visit or a checkup than your private doctor does from Medicaid. They are not seeing a reduction in need with reform. We had hoped, I should say, with lots of people getting insurance, that we would still have, that we wouldn't need as many safety net providers, since fewer people would be coming through the door saying, I can't pay. They would be coming through with an insurance card. That has not been the case. We have seen an increase in many places, partly because people now have Medicaid who had nothing, and so now they have a card and they're expecting to get some care, and they're coming in for preventive care and all that great stuff, which we wanted. But it is increasing the volume of care to them. We looked at the clinics and free clinics in Massachusetts after they did their reforms. Their reforms predated ours in the Affordable Care Act by many years, several years. They saw no decrease, and some saw increases. So we don't really know what the future is going to be for the safety net as we move forward. And I think that's going to be very important to the public health. It is very important to the public health community. So some trends in healthcare organization. This is sort of wrapping up the first of the two classes we're going to go through. The second one isn't quite as long. So there's more primary care. We want to expand it, and that primary care is less intensive and less inpatient care. So that is an important trend, is to try and get people out of their specialist's office and into their primary care provider's office so that they have those connections to coordinated care and prevention and care of the whole person rather than just one body part. Team-based care, I talked about that. That's an important trend. There's a trend to align incentives to reward value. And I talked a little about this, that now providers are going to be expected to be paid to provide quality, not just to provide a particular, say a knee replacement, but to actually get you back on your feet. And so the higher quality providers are going to be paid more. Big data and HIT. This is huge. Health information technology. Collecting information across payers to find out where we're spending money, identify problems where people are, say, frequent utilizers of the ER, for instance, maybe finding a way to get them into a primary care provider's office. Big data is being used to evaluate programs for many, many years. I mean, for forever, really. At the Capitol, we would make decisions about programs and say, this sounds like a good idea, put it out there, but there was no way to know whether it really worked. Now we'll be able to do a much better job of that. Big data allows you to coordinate care. If a doctor can find out that his patient went into the emergency room last night and with a problem that they could have come into the office with, you can call them the next day and ask, what happened? Why did you go in? Give us a call next time. You can improve patient safety as well. Nobody should be reading doctors' writing. Prescriptions should be electronic now, and that's made a huge difference in patient safety. The population health focus, which is music to the ears of people in public health, is to think about your entire panel. Like a hospital has to think about all the patients that they see, not just the one that's in front of them. So think about if you're seeing a lot more patients, say with diabetes or smoking, that you start thinking about a program to help with prevention and management of those diseases. And shifting enrollment from private to public pay. Fewer uninsured, but more people in Medicare and Medicaid, which has implications for costs and has implications for our taxes. And patient-centered care. This is a big buzzword, but the idea that care should revolve around the patient, it shouldn't be at the discretion of providers. And we will talk about that more when we get to delivery reform. So I just want to rest here and see if there are any questions about what I talked about, the system in quotes. Oh, okay. I've got quite a few here, actually. Michelle asked, are people seeking doctors outside Connecticut if there's a shortage? Um, in some cases, most of the people who are having trouble finding a doctor, especially a primary care doctor, are um, people who are on Medicaid or uninsured. Many of them are just not going to the doctor, unfortunately, and then they end up in the emergency room or they end up in the specialist's office. So to some extent, people are going outside, but you have to have some resources to be able to get outside of Connecticut to access a doctor. If people don't want Michelle asks, if people don't want hospitals that are for profit, why are pharmaceutical companies allowed to be? Oh, well, that's a really good question. Connecticut's unusual in that we have so many nonprofits. We only have one for-profit hospital. It's a very small one, Sharon. It's up in the northwest corner. So most states do allow for-profits. And pharmaceutical companies allowing to be for profit, that's an interesting question. That's a big one that we should probably have this conversation when we're not online. And Shannon asked, what is the one for-profit hospital in Connecticut? And it's Sharon Hospital. It's a very small one in the up by Torrington. And actually, it's in Litchfield County, and which is a fairly high income area, but they see people from the Poughkeepsie area because they're very close to the New York border. So they do have a good amount of folks who have higher need. And actually, when they became a for-profit, they this is something that's in Connecticut law. When you want to, and that's another barrier to for-profits coming in. When a for-profit company wants to buy a nonprofit hospital, they have to set aside usually millions of dollars in the assets that were basically taxpayers gave that institution for many, many years an advantage in the market by being nonprofit. They didn't have to pay taxes on their margins. They call them margins because they had a mission that the state supported. If that's not the case anymore, that they, actuaries and people come together and figure out what the value of that was, and it's heavily negotiated, but some part of that has to be set aside into a foundation to improve the health of the community, to continue that nonprofit mission. And so that is a very large disincentive sometimes. It makes it harder to cut a deal for a for-profit company to come in and take over a Connecticut nonprofit hospital. But Sharon did set up a foundation which provides prescription assistance and a lot of actually wonderful community health services out in that part of the state. Okay, I don't see any more questions, so I'm going to start on the public health policy arena. And you should actually, the readings for this were better, so hopefully you got some of that. In the executive branch, there's federal, state, and local level public health government structure. And next time we'll talk about advocacy and we'll talk about the structure of government and how it relates to health. But in the executive branch for public health, at the federal level, the big one is the Public Health Service, but also other agencies like the EPA, OSHA, which works on workforce safety, the Center for Medicare and Medicaid Services, obviously Medicare and Medicaid have huge implications for healthcare, agriculture, transportation, the Transportation Safety Administration. So public health is integrated into a lot of other agencies besides just the Public Health Service. At the state, the big one would be the Department of Public Health, which is wonderful, but also our Department of Social Services that provides social services, has a lot of public health functions. The Department of Mental Health and Addiction Services, the Comptroller's Office provides health care to 200,000 state employees, which is an important public health role, and the Department of Developmental Services as well. And at the local level, there are local health departments, but there are also the Board of Education obviously has a health role, economic development can have a health role. And so those are the executive branch government structures for public health. Now on the legislative side, in Congress, the Senate has the Health Committee, something and pensions. I'm forgetting exactly what their pieces are of that committee. That's an important committee in the Senate. And the House Energy and Commerce Committee has a subcommittee on health. And those are the two main legislative committees. But also Ways and Means and Appropriations have a huge role. Obviously, healthcare costs a lot of money. And when you talk about money, the committees that affect that decide where resources go have a lot to do with it. At the state, our big in the legislature, it's the Public Health Committee. I used to work there, and we have wonderful chairs in our Public Health Committee. But also the Human Services Committee hears a lot of bills that you would think would have a public health slant, as well as the Insurance and Real Estate and Appropriations Committees. And then at the local level, mayors and legislative councils have a great deal to do with setting policy for public health. Now, the roles, the Federal Public Health Service, you read a lot about this, includes the Office of Preparedness and Response, which is about biopreparedness and response. The NIH does basic research, biomedical and behavioral research, also at the campus in Bethesda, but also funds a great deal out in a lot of academic institutions. The Center for Disease Control does disease surveillance and prevention and works on public health emergencies. HRSA works on access to care for the underserved. It's actually not part of the Federal Public Health Service, but that's the chunk of the Health and Human Services that oversees, for instance, the community health centers. So they have a very large role in public health service. The FDA, I'm on an FDA advisory committee. They are responsible to make sure that our drugs and food are pure and safe. That's an important public health role. The Indian Health Service provides health services on the country's reservations, and given the access problems for many tribes, that's a very large public health role. That's within the Public Health Service. SAMHSA provides substance abuse and mental health oversight. The Agency for Healthcare Research and Quality, AHRQ, does research on healthcare quality, costs, and patient safety, an important public health role. And you will see in, I think, maybe it's not the next slide, but in a couple of other slides, what a tiny, tiny slice research has. And then there's the Agency for Toxic Substances and Disease Registry. This is about unplanned releases of pollution, waste sites, very important. The feds came up with, released in 2010, the end of 2010, Healthy People 2020. They do this every 10 years, and it is a very comprehensive plan to improve the health of all Americans. So it is the public health plan for the country. They use a very diverse and collaborative planning process, and they work at the goals are to improve the general health status of Americans, health-related quality of life and well-being, determinants of health, and disparities as well, to address disparities. So that's sort of the federal roles. At the state level, we have our Connecticut Department of Public Health. They license facilities, hospitals, practices, provider practices, outpatient surgery centers, and inspect them. They also license providers. They license doctors, nurses, APRNs, PAs. They license barbers and hairdressers. Within also the Department of Public Health, there's the Office of Healthcare Access. Right now they do certificate of need. If a hospital or a large practice wants to buy a new imaging system, they have to get permission from the Office of Healthcare Access. And the reason for that is once you buy a new piece of equipment, all of a sudden you find that you need to up the number of people. You want to keep it going. You need to keep it busy and make your bottom line back. So that tends to increase demand. So they want to make sure that the demand is really there before you buy it, so that you're not, like we said, supply-driven demand, that it's not going to increase costs. And so that's what the Office of Healthcare Access, it used to have a much larger role in healthcare planning several administrations ago, but because of politics, it's been limited, seriously limited. They also do disease surveillance and reporting. They have a public health lab They work in environmental health, community health and prevention, which includes disease prevention, epidemiology, tobacco prevention, multicultural health, family health, maternal and child health. That includes oral health, community health and support, child and adolescent health, children with special healthcare needs, school-based health centers, family planning. They do emergency preparedness and response, and they administer huge federal block grants, which is actually a very important piece. The feds give a lot of money in different block grants, and the Department of Public Health decides how best to use that. That's state flexibility, that what works in Utah isn't necessarily going to work here. Connecticut also created a strategic plan, Healthy Connecticut 2020, through also a very large collaborative model. We were all pulled in for lots and lots of meetings to talk about building we voted on priorities to build a plan to look at do a needs assessment, look at the data, what the problems were in public health in Connecticut, and then talk about what were the most feasible and most accessible solutions in our state, and put together a real plan of implementation. And they're working through it, which is probably one of the reasons we're one of the healthier states in the country. In terms of local public health roles, Connecticut uses a decentralized model. Some states, the state Department of Public Health runs local public health. We don't. Our local health departments are part of local government. We have 73 different local health departments, and they provide permits and inspections and fines and penalties for public health code violations, local emergency preparedness planning, health education and promotion, local health planning, and clinical prevention. Let's see, which is things like blood pressure screenings, immunizations, etc. I don't know if you can see this well, but we have 21 health districts that are multi-town in the state. Those are in blue. Then you can see that's New Haven right there, for instance. And some towns have their own. If it's in yellow, that means they have a full-time municipal health director. The ones in white have part-time. And the two sovereign nations, I don't know which is which, the Mohegan tribe and the Pequots have their own public health departments. So in the legislative side, the Connecticut General Assembly committees, let's see if we can go to this, the public health book. This is the public health committee bills. These are all the bills that they're looking at right now, the public health committee. This is just the proposed Senate bills. Section 2 is these proposed House bills. Let's take a look at one of them. These look kind of, let's see, let's go back to the Senate bills. There's an act establishing a task force to study hoarding, an act establishing a task force on the provision of behavioral health services to young adults. Let's look at that one. Let's see, the bill is to establish a task force to study the availability and delivery of behavioral health services to young adults. I'm betting that that's one of the Newtown bills. And you can go to the bill and you can look at it. It's in the Public Health Committee. It has not yet had a hearing. That's a pretty short one, just to establish a task force. Let's see if we can find something. Newborn screening, food allergy information in restaurants. That sounds interesting. That one has also not been scheduled yet it was referred to the Joint Committee on Public Health. It has not yet been scheduled for a public hearing. And it was introduced by Senator France from the 36th District. So anyway, you can see that the Public Health Committee has a lot of public health bills. The other committees, however, that also have bills that are relevant for public health include Human Services, Insurance and Real Estate, the Appropriations and Finance Planning Committee, and General Law. Okay, now we're going to look at financing public health. This is from the National Health Policy Forum, and you can see these are all the Health and Human Services programs Medicare is 55%, Medicaid is 29%. The public health service is 7% of all the HHS programs. Now, if you look within them, NIH, the National Institutes of Health, is about half of that. So you can see that things where we think of as typically public health are much smaller parts. The CDC is there, the Indian Health Service, the substance abuse and mental health, the FDA. These are much tinier slices of all of healthcare. In all of healthcare, we spend a lot of our tax dollars on medical care, very little on public health. And that was at the federal level. This is Connecticut's health spending. You can see we spend $2.4 billion. That's just state money. You need to double that for because we get money from the feds as well. Our Medicaid program is about a $5 billion program. Let's see, I have some questions here. Let's see. Early in the slides, you mentioned something about race and ethnicity being a factor in lack of healthcare. Yes, and we are going to get to that. It's mixed up oftentimes in income and education as well, but there are, in many cases, a role for not a role, there's demonstration that race and ethnicity can be a barrier, or, well, not necessarily. It's hard to say what causes it, but people of certain races and ethnicities are less likely to be able to get access to care. It's true. Monica has a question. Michelle asked, why did the IHS get 8%? Do they need 8%, the Indian Health Service? That's a good question. I don't really know. I've not actually spent that much time in the Indian Health Service. In some areas out west, there are exceptionally poor tribes with massive public health problems that are really difficult to address. And yes, I would imagine. And also in rural areas, you have to travel very long ways to get to people. So it's more expensive to deliver care. Actually, rural hospitals get a little bump in their reimbursement just because rural care can be more expensive to provide. So looking at healthcare in Connecticut, you can see that half of our state spending, $2.4 billion, is spent on Medicaid. And so that's health services. And then if we put this in with federal money as well, that would be even bigger. It would be another $2 or $3 billion. The next is the Department of Developmental Services, which is about $1 billion. That's a lot of group homes and expensive care for people. The Department of Mental Health and Addiction Services, some of that is public health, some of that is direct service, is $613 million. The State Employees Health Plan is $567 million, and DPH is this tiny little slice here, $112 million for public health in Connecticut. Now, I think an important theme is that most public health policy has to be implemented with or sometimes entirely by other agencies. So one of the reasons that public health isn't as well funded is that a lot of public health has to happen through other programs. And we'll talk a little about some of the kinds of what I mean by that. But those agencies may not see public health as their responsibility or their priority. Medicaid is concerned about providing care to their members, and they're not necessarily thinking about the entire population. Medicaid's actually a bad example because they do, but insurance companies, they do not get paid to concern themselves with people who are not their members. It requires integration with the rest of the system, in quotes, and you need to respect other people's perspectives and goals. And we'll talk a little about this when we talk about advocacy. But leadership often means when you're a public health official and you're sitting around the table with others who they need to get what you want them to do, and that isn't their job. You need to give up credit. You need to engage champions and partners to help you with that. Elected officials can be incredibly helpful. They get it because they're elected by people. They're elected by a population. Police chiefs, hospitals and providers, business leaders and employers often are wonderful partners. Educators and academia, labor can be a wonderful partner. And officials like the First Lady and her garden can be an incredibly important bully pulpit partner to make things happen. So champions are really important, and we'll talk about that more next class in advocacy. And leading from the outside is an important skill, and it's exceptionally important in public health. And getting people to understand why it's in their interest to help and to care about public health issues. Okay, just going through, this is a list from the CDC. I didn't make it up, they did. The 10 greatest public health achievements. Vaccine preventable diseases. Public health providers did not provide those shots. Those shots are provided by pediatricians and doctors and nurses. Prevention and control of infectious disease was provided by public health professionals, but also requires the healthcare system to identify and refer and help with the control of those diseases. Tobacco control requires public health officials, but also education, employers, a lot of other groups. Maternal and child and infant health can crosses educational boundaries and healthcare boundaries, social service boundaries, housing, a lot of other groups. Motor vehicle safety. This is a very important public health achievement, but it required the motor vehicle industry to embrace safety. Cardiovascular disease prevention was important to include the medical community. Occupational safety obviously involved employers. Cancer prevention involved community groups and the religious community, a lot of different groups. Childhood lead poisoning prevention required landlords in the housing world, and public health preparedness and response requires engaging the first responders. And so all of these required collaborations with other sectors in health, within the health system, but maybe outside public health, and then others that are outside health completely. So I think that's a really important theme, is that public health, a doctor can cure the people who are right in front of him. In public health, you're going to need a lot of partners to do your job. And so it's important to understand the system and how it works. So now moving on, and we're going to do this, unfortunately, very quickly, but health equity. This is just one slide. I'm sure you've seen a lot about health equity and how important it is that there not be gaps in care. People's health should not depend on their race or their income, their educational level, whether they live in a rural area or an urban area. That's a really important tenet of public health. Unfortunately, it does. You look at this, and I got this from Health Affairs. This is, you look at life expectancy at birth in years, and if you're among all groups, as you get more education, which is a good thing for you guys, is a good sign for you all, you're more likely to live longer as you get more education. But obviously women live longer than men, and Hispanics actually have the highest, Hispanic females have the highest life expectancy. White females do, except at the lowest years of education. But women generally live longer than men, and whites generally live longer than minorities, and people with more education live longer than people with less. I mean, there could be 1,000 of these slides. But the thing I found interesting, and hopefully you got this from your health affairs reading that you had on gaps, the determinants of health outcomes. Medical care, all that money that we're spending on medical care determines only 10 or 20% of the healthcare outcomes that we get. Behaviors cover half of them. If you smoke, you're going to have worse outcomes. If you drink too much and eat too much and don't exercise, that's going to affect your health outcomes. Social circumstances, genetics, and stress all matter more than medical care. The only one on this list that among those studies that had a less of a determinant on health than medical care was your environment. So medical care, even though we're spending a lot of money on it, it's really population health and public health that makes the difference to our worlds, which I go back to that same tiny little slice. This is where we're going to get the biggest bang for our buck out of this little slice that's going to affect all these different areas in public health. And this one little medical care right here, 10 to 20%, is what we're spending all this money on. So I think that's where I'm going to end. Check and see if there are any more questions. I don't see any. If you have a question, raise your hand, or you can email me, or I will be, hopefully, I'll be over tomorrow afternoon for office hours between 2:30 and 4:30 before class, or on Wednesday as well from noon to 1. I have office hours, so if you have any questions. But this is been recorded and will be available, and I'll send you the link. And stay warm and safe, everyone. Oh, there's a question. Hold on. Monica. Monica, are you there? I'm not hearing Monica. Okay. Oh, I have a question here. Why does public health get such a small amount when it's common knowledge that, yeah, public health, it's a great question. And part of it is because of the collaborative nature that you don't need as much money when you're not providing as many services as Medicaid. And healthcare treatments are just more expensive for all those reasons we just talked about. And Kira has a question. She wanted to double check that we don't have a midterm exam, just the testimony and topic outline due on March 9th. That's right. And the write-up for both of those assignments were posted on Blackboard. I think I handed out the testimony, and I will hand out a copy of the paper topic and outline. And also I scanned a really good article about how to do a paper analysis, how to find a good topic, a good question to ask, and think about the outline. So those are up on Blackboard. If you have any questions, email, call, or come by office hours. So seeing no other questions, I will stop the recording, and we will see you in a couple of weeks for our next class on advocacy. And I will put the readings up online by the end of the week. Take care, everyone.